the Hollow School, you'll be glad to know we've no exams going on in the exam hall tonight. Possibly it's going to take notions at the end. We're going to begin today because it's not just a very special occasion for our wonderful friend and colleague, Sven Vanneste, in a moment, but it's also a very special day in another way. And I hope you'll all join me as we go to here with us, Karen and I have to say, all credit to Karen because I put her on the spot. We had some students join us here this evening, and you explained beautifully about the connections between Belgium and Ireland, what the role of an ambassador is. So that's really very impressive, and thank you for giving the time to that. We're also delighted, Morris, particularly to join Sven's wife. You hear a professor in their own right, Professor Wingting, who's here, Professor Wingting, very similar field. We had a conversation about the research. It's a pity we don't have your two lovely daughters here, which explains that the excitement would be too much. And also, we remember your parents here this evening, couldn't join us, but they are here with us in spirit. Delighted to see so many of your students, so many of your colleagues, which is wonderful. There are actually people who came because of the topic. I know nothing about you, and I've gone around and had a lovely chat, so we're here for the topic. And two wonderful colleagues are speaking at the end who came because they've been attending the School of Psychology's short courses, which is all credit to the school, in fairness. And one of them, we made a connection. After 20 years, we have worked together previously, small world in Ireland, Chris, as always. So, with a gathering like this, we're only here for one reason, and that is to celebrate our absolutely extraordinary colleague. After 57 pages of a CV, I joke you not, I got a real sense. I thought I knew you as a head of school, a wonderful, wonderful representative really of your school. Sven in psychology doesn't need to because it is one of our stellar schools, very high in the rankings, the research and the humanity. That's the piece I've always found very refreshing about our colleagues in the school, willing to help, to be flexible, to disseminate their research. I fancy myself badly as regularly mentioning the work of our colleagues in psychology. Professor Robertson is here who would say, stop talking now, Carmel. And I don't know where my students are, but two of our students on that program that we're doing at the moment, really, they regularly suffer me taking the chestnuts from your research in school and the work that you're doing, Sven. It makes sense to people. So, on all of those grounds, we're delighted to be joined because the university is not just about what we do in here, it's the outreach. We have visitors, but also our industry partners are here. And I haven't met all of our colleagues, but we're very, very pleased to welcome our collaborators from the company that you co-founded, which is wonderful, which you can see in your office in a brain clinic. And we have Jan Ost, traveled from Belgium. And we have Professor Dirk de Reeder, very, very welcome. Also, you've travelled from New Zealand. That's impressive, extraordinary welcome. And also our colleagues from Neuromods, so I mentioned there Ross earlier. Very, very, very welcome. Because we don't do anything at this university on our own. We're very pleased to have our provost here, Professor Doyle, and our vice provost here this evening as well, Shields. And the message that keeps coming across from the leadership of this university is very clear around scholarship, yes, but the impact and reaching out in partnership and collaboration with community, with those who are engaged with us in different ways, but very particularly with industry. So we're delighted and thank you for your support here this evening. I think one minor thing, I really couldn't go through the achievements. They are quite extraordinary. I was taken with a BA and an MA in criminology. Really took my fancy, and I was wondering, what's he doing here in Trinity? In some ways, I often wonder when you are, talking to a neuroscientist, how do you do that? You're often wondering, do you've got to stimulate their cortex, but the problem is, you've got to be careful they know it's not genuine. It's the test. So it's what do you call this? I think for us here, this is a celebration evening. I don't want it to be too very serious, but we can't pass over 350. Now I did count them all. Unbelievable achievements. Quite a phenomenal record. And as we don't page index of 72. It's just to me it's at another level. So it points to the well-deserved, overdue nature of this chair for yourself, Sven. Our faculty is extremely proud of you, and indeed the whole university, with colleagues here from other faculties here. Before we hear now from Sven, I just want to say also thanks to our quartet as we did. A very, very particular thanks to Joanne McNally, to Leah who's here, Michelle, we have some of our students, Emily, Chelsea and Alex, Ian, who's always supportive of our photographer, and Danny Cormack, who's doing the video for us. Thank you for making the event that's there. So we're going to have a wonderful opportunity now to follow, I suppose, where you want to bring us on this journey this evening. We're in your hands. Congratulations.
Good evening. Thank you, Carmel, for the very nice words, and thank you all for joining us. My talk will start with a journey on tinnitus. Imagine that you hear this 24/7, day in, day out, for years and years and years. This phenomenon is called tinnitus or phantom sound. And it's a phenomenon in which you have a conscious awareness of a tonal or composite noise for which there's no identifiable corresponding external acoustic source. So people are hearing a sound that is not present in the environment. And some people hear it day in, day out. And if you hear it for more than 3 months, we call it chronic tinnitus. And today I will talk about chronic tinnitus. Now, tinnitus, and I know that some people say tinnitus, but the consensus is that we say tinnitus, is not a modern disease. It's already existing for a very long time. In classic antiquity, there were already records on tinnitus. And throughout history, you can see that there's several records and several mentioning of tinnitus. And the last piece that the quartet was playing was actually a piece by Beethoven. It was for Elise. And one of the reasons that I asked them to play it is because my daughter is called Elise, and she's very proud that the quartet was playing that. But in addition to that, there's also a reference to Beethoven and tinnitus. because at a later stage in his life, he became deaf. And one of the complaints that he'd had was that he had tinnitus. And there's a link between hearing and tinnitus that I will talk about more or later on in this talk. But there's also a theory that Vincent van Gogh, the famous Dutch painter, cut off his ear because he had tinnitus. Now, most of us have perceived already tinnitus, and you hear it for a short amount of time, for a couple of seconds, up to a couple of minutes, up to a couple of days. And it's because of listening to loud music, certain medications like antibiotics could induce tinnitus, a trauma, or another cause. But for most of us, luckily, it disappears. But we do know that in an adult population, 10 to 15% of the people are perceiving tinnitus continuously. So over and over and over again. And it doesn't matter if you just look at the Western world, it's basically all over the world, we see the same numbers coming back. So it's quite present. So I assume that there's several people in this room that probably also have tinnitus. But that number goes even up. We do know that in an elder population, that number goes up to 33% of the people that perceive tinnitus. And this is because probably presbyacusis, age-related hearing loss. We know that our hearing is getting impaired the older that we're getting, and we see that there's a link with tinnitus. But about 25% of the people that perceive tinnitus are really disabled by their tinnitus and are complaining about that they have a considerable amount of distress. And there's a lot of comorbidities that go together with tinnitus, going from insomnia, anxiety, depression, attention deficits or attention problems, up to almost being suicidal, and also social isolation. Because one of the things that many tinnitus patients have is that if they're in a noisy environment, the next day their tinnitus is a lot louder. So they try to stay away from social events, for example. Now, why the heck would the researchers spend all this time on tinnitus? Well, because there's an urgent need to better understand what phantom sounds are like, how do they work, but it can also help us to learn more about neuroplasticity in the brain, and also about auditory perception, and how the brain is compensating, and what compensation mechanisms exist. But it can also help us to learn more about neurological and psychiatric conditions, and developing new therapeutic strategies that can help for tinnitus, but in addition to that, also help for other neurological and psychiatric conditions. So just trying to understand the simple phantom sound can learn us a lot about the brain function and the development of new treatments. Now, originally, tinnitus was an ear problem. It was something that was caused in the ear. So if you want to treat tinnitus, then you have to do something about the ear. And there's some evidence for it. We do know that if you look at the audiogram and you see that there's some hearing loss, that the tinnitus reflects the center frequency of that hearing loss. Here you have a patient that has a hearing loss between 1 and 8 kilohertz, and the tinnitus that patient is perceiving is actually the average between the 1 and the 8 kilohertz. There's other research that indicate that it's not the center frequency, but the edge frequency. Where the hearing loss starts, that's the sound that people are perceiving. So, but if it is an ear problem, ENT surgeons thought, well, then it's a very easy thing to fix. What we do is we cut the auditory nerve. We do a resection of that nerve. Patients become deaf. That's a side effect. But at the same time, they do not perceive tinnitus anymore. That was the original idea. So in the 70s, that's what they did. But most people still had their tinnitus, unfortunately. So the solution seems to be not, or the cause, although it's probably something related to the ear, there's something more to it. And 20 years ago, we started to investigate what is actually happening. And our lab, together with other labs, were able to show that the brain plays an important part in tinnitus. And we were able to show that there's actually increased spontaneous activity in the auditory cortex. So this is the auditory cortex, that's the area in the brain where you perceive sound. And you see that although there's no input, you see a hyperactivity in that specific area. And this was also confirmed by animal research. And in animal research, it was shown that there was increased synchronized activity, so neurons that would fire together in that specific area in the auditory cortex. And in addition to that, also in animals, it was shown that typically you have an auditory cortex that is tonotopic organized. So it's organized from lower frequencies up to higher frequencies. But in people with hearing loss and tinnitus, what you would see is that there's an overrepresentation of certain frequencies in the auditory cortex. But it doesn't stop at the auditory cortex. It's basically down the whole auditory pathway, going from the cochlea up to the cochlear nucleus, inferior colliculus, the medial genetical body of the thalamus, and the auditory cortex, that you see increased hyperactivity, increased spontaneous firing, and increased synchronization. And that exact spot correlates with how loud people perceive their tinnitus. So the more spontaneous activity you see in that area, the louder their tinnitus is. But how can we explain this? About 30 years ago, Rodolfo Lindes introduced the theory of thalamocortical dysrhythmia. And the idea was that, well, at rest, there's still brain activity happening, also in the primary cortices, such as the auditory cortex. So there was resting state activity. But because there was reduced input, a lack of input, there was a specific spot where you had decreased activity because of the lack of input. But typically, the resting state activity is there to induce lateral inhibition, to induce rest at all the neurons in the auditory cortex. But because there was a decreased activity, a halo of hyperactivity started because there was no lateral inhibition anymore. And this is probably what we're also seeing in the auditory cortex in tinnitus patients. But why is this so important? Well, we were able to show that thalamocortical dysrhythmia plays a role in tinnitus, but it also plays a role in chronic pain as well as Parkinson and depression. So by investigating one disease, it helps us to better understand other neurological and psychiatric conditions. But then, I was trained by neurosurgeons. The next question is, how are we going to treat these patients? And we have a device which is called transcranial magnetic stimulation. It basically sends magnetic pulses to the brain, and we can change brain activity. We can modulate that brain activity. And we can target a specific area. And of course, in tinnitus patients, we were hoping to target the auditory cortex by sending magnetic pulses and changing the activity in the brain. And we were able to show in patients that we could suppress, independent on how many magnetic pulses that we were sending to the auditory cortex, that we could suppress the tinnitus to a certain extent, up to 25%, but only for a short amount of time. But we thought, oh, this is very interesting. So if we can modulate it, it's a confirmation that indeed the auditory cortex plays a role in tinnitus, but maybe we can translate it into a treatment option. And again, I was already making a reference to neurosurgeons, so the next thing would be, well, let's implant these patients with a cortical electrode. So this is, for example, a patient that got an implant, a cortical implant covering the auditory cortex. And the idea is that by implanting this patient, we can all the time manipulate that specific area and hopefully suppress the tinnitus. And depending on how we were stimulating, we were able to suppress the tinnitus loudness up to 60%. But as you can see, not all participants were responding to the treatment. We were able to get up to 29 people from the 43 people that we implanted that had a significant suppression that was really life-changing for them. But still, there were some people that were not responding to the treatment. And we were a little bit upset about it, because when we implanted the first patient, that patient was tinnitus-free. So we were already drinking champagne, we found a solution for tinnitus, but then, like always, if you do the second patient, it didn't work. And we were wondering, why is that? Why is it that some people respond to that treatment and other people do not respond to that treatment? Well, if we start looking at responders versus non-responders, what we saw was actually that the auditory cortex was not playing a role. It was a deeper structure, which is called the parahippocampus, which is an extension of the hippocampus where memories are stored. So all of a sudden, the parahippocampus was playing a role in tinnitus. And if we start digging into what was actually going on, if there was increased connectivity between the auditory cortex and the parahippocampus, those were the people that were responding to the treatment. So probably we were not stimulating the auditory cortex, but we were still stimulating a deeper structure, and it was because of this connection. And although this was controversial, that all of a sudden not the auditory cortex, but another brain area would play a role in tinnitus, we start digging a little bit more and trying to find an explanation why that is. And what we were able to show is that depending on the hearing loss that people have, you see that there's a different compensation mechanism. If there's a mild hearing loss, you see increased activity, spontaneous activity in the auditory cortex. But if you have severe hearing loss, all of a sudden that hippocampal area starts to play a role. And this was very controversial when we were first starting to publish this. And a lot of people were saying this is not possible. But there was a group in Newcastle that was able to show in people that had intracranial electrodes and were able to record directly from that area, showing that in tinnitus patients, indeed, they were able to pick up from that specific area changes, spontaneous changes, confirming that indeed the parahippocampus might play a role in some tinnitus patients. But why is that? Well, we came up with a model, and it all depends on the amount of hearing loss. So if you only have a small auditory dip, a little bit of hearing loss, what you see is that there's decreased lateral inhibition, thalamocortical dysrhythmia starts to play a role, and that could be explanation. But if it's more severe, that hearing loss, then you see another mechanism. You see all of a sudden map plasticity playing a role. Those tonotopic map that is changing. And if you have a really large auditory dip, so really severe hearing loss, then the parahippocampus is playing a role. And we were saying that basically the brain is filling in the missing information, the information that you're not able to perceive anymore. And that's what's happening. So we thought that we had the solution. But then, of course, we were able to explain people that have hearing loss and tinnitus. But what about people that have hearing loss and no tinnitus? And what about people that have tinnitus and no hearing loss? So we're still able to explain only a part of the problem, but not the full problem. So we had to dig a little bit further. And we started comparing people that have hearing loss and no tinnitus with people that have tinnitus and hearing loss, people that have tinnitus and no hearing loss, and started comparing that. And what we saw was that if you just look at people that have no hearing loss, that have no tinnitus but do have hearing loss, all of a sudden a frontal area was showing up. It's called the ventromedial prefrontal cortex, pregenital anterior cingulate cortex. If we look at people that have no hearing loss, that have tinnitus, and compare those to no tinnitus, again, that same area was showing, but these people were hearing tinnitus, the auditory cortex was also showing up. And if we look at people that have hearing loss and tinnitus and compare to no tinnitus and hearing loss, again, that frontal area, that pregenital anterior cingulate cortex, as well as the parahippocampus was showing up. But what was also important to was actually that it's a communication between that frontal area and those more auditory related areas that is really important. In people that have no tinnitus and hearing loss, you see that there's increased communication going from the frontal area, the pregenital anterior cingulate cortex, up to the auditory cortex. And in people that perceive tinnitus, independent if they have hearing loss or not, what you see is decreased activity going from that frontal area to the auditory cortex and the parahippocampus. And what is happening is that this increased activity, this specific area, is signaling to that area, okay, let's put a brake, let's cancel whatever hyperactivity is going on. It's a noise cancellation system. But it seems in tinnitus patients that that brake is not working properly. So your frontal areas are not basically saying, okay, ignore that sound, just block it out, it's not relevant. And this fits with a model that was introduced by Joseph Roschecker, where he was showing that the ventromedial prefrontal cortex is playing an important role in that noise cancelling mechanism or gating mechanism, and that you see the same in tinnitus as well as chronic pain. It seems that a very similar mechanism is playing a role. But what about the nucleus accumbens? Well, we were also able to show that the nucleus accumbens was playing a role in that story. But to go back to that specific area, the ventromedial prefrontal cortex, it seems that it's even a more important area than we originally were expecting, because we looked at several neurological and psychiatric conditions. The first 4 is what we call thalamocortical dysrhythmias, and the last 4 are reward deficiency syndromes. And in all of these pathologies, every time this area was showing up. So it seems that it's really a controlling area that is mitigating and are affected in all of these conditions. In addition, there was also the dorsal anterior cingulate cortex, and I'm going to talk about that later on this talk. So again, the question was, can we start manipulating that frontal area? And we had a study that was separate of the tinnitus story, where we implanted people with a CT-C2 electrode, a great occipital nerve electrode. So we were covering the great occipital nerve, and the great occipital nerve is a nerve that's sending information from the back of your head to your brain. And if we're these were in pain patients, if we're stimulating that specific nerve, we were able to induce changes in that specific area, the pre-general anterior cingulate cortex, and of course there was significant pain reduction up to 6 months after the treatment started. But we were also able to do this in a non-invasive way. Of course, the treatment didn't take that long, but there were also a reduction in pain percept because of stimulating that great occipital nerve in a non-invasive way. And another group in Michigan applied the same thing in a specific type of tinnitus, where they again stimulated that specific nerve, and at the same time were presenting sound, and they were able to show an effect up to 1 year after they started the treatment. So this is quite interesting that we can, with just stimulating the peripheral nerve, can modify brain activity and help patients. So it seems that it's more like a ripple effect. You start with one disease and it can help other diseases. But we wanted to know more about what is the mechanism of action of great occipital nerve stimulation. And we start digging into the literature and trying to really understand the anatomy, and we were able to show in the study that that great occipital nerve connects to a specific brainstem area, which is called the nucleus tractus solitarius, that is then connected to the locus ceruleus, that is important in the release of a certain neurochemical. But it's also connecting to other brain nuclei that are also important in the release of other neurochemicals. And all of these neurochemicals play an important role in a lot of psychiatric and neurological conditions, because most treatments that are developed currently for a lot of diseases, going from anxiety, depression, up to ADHD, OCD, memory deficits, and so on, are basically targeting these areas and trying to manipulate these specific neuromodulators. So this is quite intriguing. But what is interesting is that it's not only the great occipital nerve that connects to that, it's also the trigeminal nerve and the vagus nerve are basically following the same pathway. And there are currently treatments using that specific pathway for example, people with an ischemic stroke that need to have neurorehabilitation. And this is an FDA-approved device now for people that want to expedite their recovery after a stroke. But there's also trigeminal stimulation, where there's a group here in Dublin, Neuromod, that has actually developed a device where they're stimulating the tongue, activating that specific pathway that shows long-term effects in tinnitus patients up to 1 year after. And they were able to show that about 80% of the people were responding to that treatment. So this is quite encouraging. But our lab even continued to do research, and we're able to show that stimulating that great occipital nerve, we can induce memory and learning effects. And we're actually now doing a clinical trial in people with amnestic mild cognitive impairment and early AD to see if we can help them with the reduction of memory deficits. But also for executive functioning, this seems to help. If you combine it with an executive functioning task, you can actually improve executive functioning, which is now going to be investigated in people with Parkinson, and we know that people in Parkinson also have an executive functioning problem. And also for motor learning, we're running a clinical trial where we now want to see if a great occipital nerve stimulation can also help in motor rehabilitation using a non-invasive approach. So it seems that starting with tinnitus can help us to explore a lot of other things and help us to explore also a lot of treatment options for other neurological conditions. In the beginning of my talk, I was saying, well, we have tinnitus and about 25% of the people are really affected by it. And if they're really affected by it, we don't say that tinnitus is a symptom anymore, but a disorder. And we say that it's a tinnitus disorder when it's associated with emotional distress, cognitive dysfunction, and or autonomic arousal, leading to behavioral changes and functional disability. So we wanted to try to investigate, okay, if people are really suffering by the tinnitus, what is changing in their brain? And what we saw was that there were changes in the subgenual anterior cingulate cortex as well as the dorsal anterior cingulate cortex. And that in people that are really stressed about their tinnitus, we saw increased connectivity between the more auditory components, so the auditory cortex and the parahippocampus, and those more frontal areas, specifically the subgenual anterior cingulate cortex, in people that really were distressed. But what is intriguing is that what we were seeing is not tinnitus specific. It were just people that were very stressed about their tinnitus, where we saw these changes in brain activity, but the same also applies for pain. People with chronic pain can also suffer, and we see that the same areas lighting up. The same mechanism applies. For Parkinson, we see the same thing. We do know that tremors are induced or have, to a certain aspect, induced by tremors. And also in depression, we see that specific area is showing up. So we developed a new type of treatment where we're targeting those two areas. And we were able to modify the tinnitus and the distress-related tinnitus. And currently it's also used in several clinics where they're using this approach for people with depression that are not responding to any medication anymore. And actually it's also FDA approved where they're targeting that specific area for people with major depression using deep brain stimulation. So, in summary, it seems that tinnitus is more complex than we originally were thinking. Originally it was an ear problem, then we saw that it was indeed that the brain was involved in it and that the auditory cortex or the auditory pathway was involved in it, and we call it lateral pathway. But there's a medial pathway involved related to the emotion component related to the tinnitus, and that there's also a descending pathway going from the pregenual anterior cingulate cortex where the brake doesn't work that properly. But what is intriguing is that the exact same pathways also apply to chronic pain, to neuropathic chronic pain. The exact same pathways, with this, the only difference is that instead of the auditory cortex, the somatosensory cortex is playing a role. So investigating tinnitus can also help us to understand chronic pain. But it can also help us with a lot of other conditions, as I already showed you. And neuromodulation or brain stimulation seems to be an avenue to help several people, and keep in mind that all the research that we're doing in brain stimulation is always done in people that do not respond to any other treatment anymore. So still with this approach we can still help people in addition to people that are treated by medication, for example. But throughout all the studies that I was showing, we were able to suppress tinnitus to a certain extent, but not eliminating the tinnitus, unfortunately. And one of the reasons is that so far we have been focusing on one of these pathways, but not on all three pathways. And probably if we develop treatment options where we work on those several pathways, probably we get to better results. But in summary, starting to look at the auditory perception helped us to better understand neural mechanisms. It expanded into understanding other neurological conditions and the development of therapeutic strategies. The fact that I'm here is not because I worked hard. I've worked, of course, hard, but it's also because a lot of people helped me down the road. And I always say it takes a village to raise a scientist. And I want to thank several people that really helped me throughout my career. And first of all, I want to thank Dirk de Ridder. He was my mentor when I was doing my PhD. He really learned me a lot. I mean, he was a neurosurgeon, and if I had an idea, his remark was always, let's do it. So I also want to thank John Hart, who was a professor and a colleague in Texas, and he showed me how things are done in the US, how to apply for funding and things like that. So he really helped me to develop my career. And the last person that I want to thank is Ian Robertson, that convinced me to come over to Trinity and showed me around here in Ireland how to set up a lab and to find funding to do all of this research. But last and not least, I want to thank my family. My wife really gave up a lot of things. I mean, she was willing to move with me to the US when she was still finishing up her PhD, and she had to finish up her PhD when we were already moved to Texas. My daughters, my oldest daughter was born in the US, then moved to Ireland, now lives in Belgium, and my youngest was not aware of all of this because she was born in Belgium. So I really want to thank my wife for all the support and all the dedication and all the things she had to give up to make me successful in my career. So thank you all.